Okay. Thanks everybody for joining us this morning. I'm going to apologise in advance. My flight got in at 2 a.m. this morning, so I'm still a bit, and the papers only arrived during the time I was away. So I have read them, but I might not be as fully up to speed as everyone else. So if we begin, as I say, a warm welcome, and thanks for everybody attending this morning. Do we have any apologies, Craig?
No apologies, Chair.
Okay, thank you. Item two, the closure of pecuniary and non-pecuniary interest relating to the matters we're going to discuss today. Item 3, minutes of the last meeting. We're asked to agree the minutes of the previous meeting, and I wanted to ask if there are any matters arising that aren't met elsewhere in our agenda today that you wanted to raise. So can I accept them as a true record of the last meeting?
Yes, I agree with them.
Thank you. Item 4 is Lancashire Special Educational Needs and Disabilities Partnership, an update on the accelerated progress plan. I believe you're going to lead that, Sarah.
Well, I think Zoe's probably going to lead it, Jane, but I'll just do a brief intro. So, as you all know, we had our full inspection back in November 2017, and there were 12 areas that were subject to ongoing monitoring as an outcome of that inspection. We had a revisit in March 2020, just before we went into lockdown, where 7 of the areas came out, 7 of the 12, and this subcommittee has been part of our scrutiny and challenge around the other 5 areas. So as usual, what we'll do is go through each of those areas, updating and giving evidence in terms of what we've done to improve each of those areas. And Zoe's circulated and produced a really robust update on each area. And I think based on your feedback last time, we have, when I say we, Zoe and Sarah have shifted the way we've presented it, so it is much more, it relates to this is what you told us and this is what we've done, so that it quotes directly from the report that we received, and then we've said what we've done against each of those areas. So I'll hand over to Zoe then to go through the detail, if Zoe is here. I'm hoping she is.
I am indeed. And I've noticed there is some feedback, so if anybody has got your mic still on, could you please mute yourselves and then we can make sure there's no feedback. Thank you. The first thing I wanted to say about was sort of building on what Sarah has started as an introduction around the fact that we have gone through a process with 5 actions as a result of an accelerated progress plan. And we're coming up to our monitoring review meeting on the 29th of September with Department for Education and NHS England. At that review monitoring session, they will check through whether or not we have made sufficient progress. And it's really important we remember these 2 words, sufficient progress. This is not saying that we have done absolutely everything that we need to do, but it is saying that the monitors are satisfied that sufficient progress has been made since the initial inspection of 2017 and then the inspection revisit of March 2020. And it's also worth noting that the inspectors in March 2020 went off piste a little bit, and as well as the letter that they read out, they also read out an additional statement to us, and we can't forget that, because that statement was making it really clear how impressed they were with the progress that we had been making since November 2017 across all 12 of the actions. So they weren't saying that we'd done nothing. They were saying that they felt that we had further work to do to demonstrate to them that we had made sufficient progress. And I feel very confident with the work that we've done in pulling all the evidence together for this monitoring review, that we are in that position where we can demonstrate sufficient progress has been made. So I asked Craig to start off with this page for you all so that you could see what the Department for Education are asking for as evidence and what we are providing as evidence. Though, Craig, I'm aware that I am getting old and I might not be the only one who struggles to see the size of the font. So I wonder if you could just increase the font slightly. Thank you. That's majorly better. I can read it now. I don't expect you to all have read it all, but equally I'm not going to read every word on this. What I wanted to highlight to you is the documents that we are supplying as evidence to the Department for Education and NHS England at the end of the month. First of all, they've asked for our Accelerated Progress Plan update. That is contained in Appendix 1 of the self-assessment that we've produced. You've now, sorry, you won't have it until the minutes go out. Craig is going to send out the updated version. The version you've got of the self-assessment is a draft because we hadn't finalised it at the point where it needed to go out to you all, and my apologies for that. It's been an immense piece of work that's taken 6 weeks to produce, but it's been worth that 6 weeks of work. So you did receive a draft. There are minor changes, and you will receive a copy of the final document. So the Accelerated Progress Plan Progress Update is contained in Appendix 1. However, it's important that's accompanied by the next document there, that is the KPI Enabler document. In March this year, when we had our review monitoring meeting with DfE and NHS England, we had an agreement with them that the KPIs that are on the scorecard of the Accelerated Progress Plan were not actually working for us. In using those KPIs, we identified that actually the KPIs we'd been encouraged to use weren't good measures of whether or not we were doing the improvement work we were required to do. So before the March meeting, we'd already started working with what we'd referenced as a KPI enabler document. That document we're submitting as evidence alongside the scorecard, the APP progress update, because we felt it's important to demonstrate to the DfE that we have been doing work aside from simply doing surveys that identify what people's opinion of services is. That document, again, we can send that out to you after this meeting so that you've got a copy of that and you can see how we've identified actions and deliverables as being part of the measures of our success in the right direction. Then we've got the self-assessment, which is from page 5 of the document that you've received in draft, and then the presentation that I'm about to take you through. On top of that, we're also sending through, which you'll see in the second row, we're also sending through the SEND plan and turning words into actions. These two documents are really crucial for the fact that we're demonstrating to the monitors that we recognise our work doesn't stop on the 30th of September. Yes, we have been doing significant improvement work, and so having a continuing SEND plan does not reflect on the fact that we believe we've got to start something brand new from the 1st of September. We've given ourselves the date of the 1st of September this year that we've started that work from. It actually reflects the fact that we recognise that there's ongoing work with our statutory duties, what we define as our must-dos. There is also quality improvement work that as we learn and grow and develop and we hear more from parent carers and children and young people, we can improve the quality of the work we do, which is our should-dos. And then the final one is our gold standards of those things that we could do. So the SEND plan is our high-level piece of work that I know some of you have been involved in terms of the original development through Think SEND events and then on with our consultation, and we thank you for your involvement in that. Turning words into action is taking that high-level plan and putting it into an operational context and ensuring that we support our teams and services as they engage in the delivery of the SEND plan. So that's all I wanted to say on that front page, just to contextualise the work we're doing. So Craig, if you could unshare that and share the presentation for us instead, that would be great. Thank you. Craig's doing a great job as my trusted assistant on the side. I'm not going to ask you to get into one of those boxes though, Craig, where I get the saw out and start sawing through the middle, I promise you. So as Craig's pulling that up, the start of the presentation is simply a reminder of the position that we were in. So Craig, you can go on to page 2, thank you. So the position that we're in terms of the 5 actions that we need to deliver on. Our leaders' understanding of the local area, joint commissioning, ASD waiting times, transition in healthcare and the local offer. We've then also highlighted the fact that we have been through a very tough time since the revisit. So the revisit completed on, I can't remember the exact date, but the 11th or 12th of March. And we went into lockdown around about the 23rd or 24th of March. So we know that the pandemic has had an impact on our ability to deliver. In the early days, that was an impact in terms of capacity to deliver for a lot of staff who were redeployed or asked to work on our COVID response. And there have been some ongoing impacts for some groups of staff around capacity to deliver on the ongoing pieces of work we've done. However, it's important to note we've carried on and delivered. And I think that it's really important to recognise the benefits that the COVID response has given us, which is that it's strengthened our integration. It's strengthened the way in which we work as partners. Whilst we described ourselves as partners 18 months ago, I think we would all say that we are much stronger in our partnership now. We are able to work together much quicker and in a much clearer way because of the relationship forming that has happened as a result of COVID responses. We've also found that we've got greater responsiveness in terms of the way we work with our healthcare providers, which, considering that some of the pieces of work we've done have been specifically around working with our healthcare providers, that's helped significantly with the send improvements that we've delivered. So as a partnership, we believe that's a great strength to us as well. But also with our children and young people, with our parent carers and with staff across quite a large area that is not only large in size but difficult to travel around as well. We've been benefiting from the fact that we now use routinely these kind of remote working systems. So that's again a benefit to us, that we've been able to hear the voices of more people involved in the work that we've been doing and also in the work that we're going to be doing in the future. And Sarah's just said something there in the chat as well, which I didn't quite catch it in words, but you'll be able to all have a look at what she's adding into that comment as well. So to move on, the next slide then shows us how we are delivering, and you'll see, I've been asked by Edwina, by the way, Edwina Grant said that she would like me to use greys rather than colours here in case people are printing this out, particularly if this does go to ministers. So the light grey is the work that we've completed on, the dark grey is our single action that we've not completed. So this is a sub-action of action 4, transitions in healthcare. However, when we use the KPI enablers, what we're able to identify is that although we've not completed on that sub-action, which relates to the engagement of primary care, we have actually done all of the preparatory work for that action. And that's because we've now got a really clear understanding of who the cohort of children are at 14 and what direction they need to be taking in terms of their pathway for transition. So we know the group that are being transitioned to their GP service so that they are then able to be prepared for how that is their pathway for transition, as opposed to an expectation that they would go into adult services. So all the preparatory work has been done for 14-year-olds. 15 plus, some of the preparatory work has been done, but not all, and that is our ongoing work with the engagement with primary care. So we know that we are in a better place, but we're not in a perfect place with that single sub-action. All other actions are completed. So I'll take you through each of the individual actions now. On to the next slide. Thank you. So what we've done on this approach this time around as a presentation to you is a reminder of what each of the comments were from the inspectors in March 2020, and then pulled out of that just some key points. It's not everything we've done. There is a massive work that has been carried out on each of the actions, but also to tell you what we are planning on doing going forward. So in terms of action 1, the clear information I think here is about making sure that we know what we're doing. The action plans that we now have in place, the highlight reporting processes that we use are now accepted as standard, not only by our leaders, but by people who are delivering the projects as well. And we've got that ability to keep projects on track and to check and challenge when there is something that is blocking our delivery. We've been using surveys, focus groups, data dashboards to help to illustrate the impact and effectiveness of our changes. And again, that's making sure that we are able to keep projects on track or change direction where we need to change direction, which has happened with a couple of items. And I think there's one important item in terms of our data dashboard that reflects into the ASD action, where we reported to parent carers that 100% of families had been communicated with about where they were on the waiting list. We got feedback from parent carers that actually no, that wasn't their experience, went back to the providers, and the providers did a piece of work and identified that they had actually missed some people and were able to then rectify that situation. And it's only through having strong data that enables us to be able to do that, and through having conversations with the right people that enables us to do that process. So that strengthens not only our understanding, which is a big bit of what this action is about, it also strengthens our responsiveness to the work that we're doing. And then the final one there you've got is the systems being in place to collect the views of children, young people and parent carers at various points. Previously, we used the POET survey. Please don't ask me to say what POET stands for. I can't remember it. But I'm hoping that somebody like Sarah Callahan can remember. Effectiveness is in there, I think. Observation might be one of the words. But that survey wasn't working, partly because so few people were responding on it. We've now got a range of different surveys at the point of service delivery, as well as across the systems. And we've had in excess of 100 responding on some surveys. We've had open field boxes where people can do free text responses, as well as just ticking a box. And that's strengthened the feedback that we've received. And we're finding from both the children and young people and the parent carers that they're finding these approaches much more useful for getting their voices heard. So our ongoing work for Action 1 is around the good practice that we have introduced, carrying on to use that good practice and also strengthen it. And it's also about our implementation of the SEND plan for 2021-25 that's been designed as high level so that we know what direction we're going in for the next 4 years, as well as then having operational detail for being able to deliver at service level. So we've got strategic, operational and individual level improvements in place. I'll stop there in case anybody has any questions in relation. Oh, sorry, there is another page to Action 1. So if we can just move on to the next page. So this is giving you some, and again, I'm not going to read through each of these, but it gives you some of the comments from people involved with this work, and also illustrates the KPI scorecard that we were instructed to use. Just for clarity, we're on 1B. It says varies. The variation is because we have a number of surveys across a number of services. And so so one service, for example, has a 76% response, positive response rate, whereas another has 100%, and we've got various in between 76 and 100. So that's why it says varies. So over to yourselves in terms of any questions, check and challenge that you would like to present.
Any questions? Can't see any hands up. Oh, hold on a minute. I think it was Debbie first.
Thanks very much. And apologies for being late. I had some problems with Teams this morning. It was noticed Monday morning. The first thing I was going to say is thanks so much for the report, because I think that the format's brilliant. I really, really like it. So the fact that it's so systematic and it helps us to track back around what the challenge was and then look at progress and look at impact. So I'm sure it's going to go down really well with the inspection team as well, because it is really clear and focused. On this one, I was interested in that sort of variation around feedback, because as you just said, Zoe, sort of the parent carer feedback does vary between 76 to 100. So the 76 is above where we had hoped to be, so it's a fantastic achievement anyway. But I just wondered sort of wanted to check that we've got a real in-depth understanding of where that variation is, the reasons for it, and sort of a finessed approach in responding to it. And it's hard to sort of get a sense about whether it's those services with most young people that have the lowest rating. So I was just interested in unpicking that a bit, if that's okay. Thank you.
So to be frank about it, Debbie, what we have found is that surveys are not an ideal way of tracking our progress. So we have included this because this is what we were expected to use as a mechanism for measuring our success by the DFE when we produced the Accelerated Progress Plan. Experience has shown us that actually on some occasions having 76%, what does that actually mean? You know, is it really something that helps us to deliver the right services in the right way at the right time? And actually, no, it isn't always the right kind of approach. So we've included it. It's well done to those services that are achieving success. We know that, so the 100%, for example, that's with our pathway navigators that are a new post for ASD. And we have 100% telling us that the service is exceptional. Now, that's then helped us to move on into adding to those roles and to lengthening the period of time that the pilot will run as well. So that is great. But again, having 100% isn't necessarily telling us the right thing, because 100% is that currently there are people who are going, oh, wow, thank goodness, I'm getting the support I needed. I'm actually going to be more interested in the ongoing feedback we get when people their expectations are raised, and then they start to say, well, actually, really what I need is, and they provide us with meaningful information that helps us to continue the improvement. So in truth, I'd say this isn't a good measure of what we are doing. We did push back at DFE last year to say that we didn't feel that surveys were an appropriate mechanism, and we were informed to use them. And that's why we then went down the route of having the KPI enablers that is about delivery of some of our actions, sub-actions of things that help you to get to a place where it's much better. So, for example, with transitions, the only way we can know that we are doing transition conversations is to know who our cohort is as a start. So, you know, it gets to that kind of base level that we can only improve things by first off knowing who are your 14-year-olds who are going to need to transition into adult services, and which route to adult services do they need? Is that back to their GP? Is that to another provider? Is that in a service that's within this provider? So again, you know, having surveys isn't necessarily the best measure of success. Does that help, Debbie?
Kevin, next.
Hi, thank you. Thanks very much, Zoe. And can I start by seconding Debbie's comments on the format of the report, which I thought was really informative and set out in a way that sort of makes the most sense of this report that I've seen so far. It puts some meat on the bones. Just a couple of points around the reporting of the targets. I note that I think it's at least 3, if not 4, of the targets are being met and well met. So I would have to say this, wouldn't I? Are we being ambitious enough there? And whether or not that needs to be reconsidered. And also, there is a slight danger when you start reaching targets like that, and other people may then start to push you to focus more on the ones that aren't being met, with the risk of slippage. So if this is going to be a plan that's going to remain and continue, it may be something to consider to look at those targets and see if they could be made slightly more ambitious. The one that I just wanted to ask a similar question to Debbie was, because it possibly worries me the most, are the targets around the local offer.
So Kevin, can we come to the local offer when we get to that action? But
sorry,
in terms of that overarching view,
absolutely,
if I can hand over to Hilary, because I think Hilary has a very good response that I was listening to her say about the ambition of targets. So over to you, Hilary.
Thanks, Zoe. Thank you.
Thank you, Zoe. So thanks, Kevin. I think it's really important, isn't it, that we recognise that the targets we've got here are about getting to that sufficiency of or demonstrating that we've made sufficient progress. They're not about where we really want to get to next. So I think you're absolutely right to make that point. And as we develop the SEND improvement plan for the next period of time, we will want to stretch ourselves further. We will want to drill down and have new targets that that enable us to go further. So I think it's a really important point that you make, that we need to recognise as we develop the next plan, because what we can't have is a situation whereby we're appearing to be 100% on all of the things that we've got here to meet sufficient progress, but actually we haven't stretched ourselves further to achieve the things, all of the range of things that we want to across the board, not just within these 5 areas, but actually all of the provision of services to children who have an SEND need.
Okay, thank you. That sort of just assures me that you're in a position, at least considering that going forward, and I take your points about it's where we are now, so thanks for that.
I think Sarah's just popped a note in the comment box to follow up on that as well, Kevin. So
okay, I'll check that out. Thank you.
And Councillor Green.
Thanks, Chairman. Thank you, Zoe, for the report and for your presentation. And I echo the comments regarding the style of the report. It makes it very easy to read. You did mention that we'll be receiving an updated copy of the plan with the minutes. I'm just wondering whether there'll be any changes that have been made, whether they'll be shown as track changes on that update, which will be helpful for us when we can look back at it. Thank you.
I do apologise, no, because it's the document that's then going to the DFE and NHS England, so I haven't tracked changes. The changes are in terms of an introduction part to remind DFE, NHS England, the position we were in terms of the comments that were read out by inspectors. I felt that was an important thing to add in to that self-assessment. Some of the KPIs weren't 100% correct, and there's some very minor changes in language. So they're not, it's not significant changes that have been made. It's very small changes. So you received very close to the finished version. I think there's the appendix. The appendices might have changed. I think I might have added one extra in since you received it, which will be the Accelerated Progress Plan scorecard, which originally was a separate document. So there's that extra document. And then we've reviewed our evidence list and questioned whether some things that a couple of people had said, oh, that will be ready in time. And it's not. So, for example, the new homepage, the landing page of the local offer, it's actually not going to be ready until around about the 29th of September. So we shouldn't include that as evidence because it's not actually evidence yet. So my apologies that because I've done it for the inspectors, the monitors, I haven't actually done the track changes.
Thank you.
Councillor Townley.
Yeah, it is slightly more practical in that I'm just wondering whether we have anyone that we are tracking through this system as a trial. Yep. Having seen that there were some that had obviously not been contacted, it would just be, and then we went back and obviously rectified that. And knowing that people don't just stand still, no matter what's going on around us, has a selection of those 14-year-olds who are having to transition or since all this started, are they being monitored?
So can I, that's related to the transitions one. So could I come back to that when we go through the transition action? I just gave that as an example to respond around the survey results. So I'll come back to that on the transitions. Thank you.
Sarah?
The only thing I was going to add, and apologies, sorry, because you're going to come back to it, but I was just going to say, Cosima, that one way we do what you just said is through the audits of our plans. So our education, health and care plans, for instance, we have regular audits, and where things emerge, you know, where there might be a theme that comes out of those audits, then that shapes the training, you know, for the staff. So it's not quite what you were asking in terms of tracking individuals, but it's how you close that cycle, isn't it, of improvement. You look at the audits and you continue to look at the audits so you can see what areas are improving in those plans and what areas require training to staff. So it was just an illustration of the process that you were referring to.
Thanks, Sarah. Kevin, Is yours a legacy hand there, or do you have another question? Do you want to move on to the next slide, Zoe?
Okay, thank you. So action 2, Craig, if we can go on to the next one, thank you. So action 2 is our joint commissioning. Again, I won't read through the top box, which illustrates what the comments from the inspectors in March 2020. In terms of the next row down, this is our position as we are at now. So we now have strengthening. I think it would be fair to say that at the point of March last year, we already had a strong commissioner relationship. So it would be wrong to say that we're now currently in a position that's brand new, but I think it's fair to say that it's a strengthening commissioning relationship between the council and NHS commissioning colleagues that is simply growing and growing. So, you know, it can only benefit our families long term because of the strength of that relationship. We have as well now a Lancashire County Council commissioning group that meets, in fact today I believe is the next meeting, so it meets every other month, and that looks at those issues where there are overlaps or gaps or deep dive conversations that need to be had between health and the local authority, as well as having representatives from Lancashire County Council on the integrated care system, children and young people's commissioning network. So it's very strong links for the joint commissioning work. We've now got the robust joint commissioning framework reviewed and approved through the SEND Partnership Board and other groups, and we have a commissioning dashboard, and that dashboard informs the conversations that are had. The bladder and bowel framework has been co-produced and it's been approved by the Collaborative Commissioning Advisory Group, and that is now in the process of being commissioned and implemented. Because that means that some families could have been disadvantaged through needing a service prior to the commissioning arrangements being in place, such arrangements have been dealt with on a case-by-case basis to make sure that no family is disadvantaged. So commissioners are working together to make sure if they've not yet got the service in their area, that another area is supporting them. We're looking as well at making sure that that is dealt with from a long-term perspective, so it's not just about what do we need to do now, but also reviewing it. And in that context, it's been combined in with the next point, which is about the specialist community nursing services. The review was carried out, a mapping exercise to understand what services there are. We were disadvantaged in that the inspectors gave a rather generic comment on this and said that we would have it all sorted out by the end of a 12-month period. What became clear was that this is an enormous piece of work to be done, but the work has enabled us to make sure that we know what work has got to be done, the gaps that have got to be dealt with, and some of those gaps relate to workforce development, as in long-term workforce development, as well as some long-term investment requirements. And we have an agreement for a framework over a 4-year period to make sure that we can support that work. And then the final one that I've put in there is around the schools knowing about their public health nurse. So that has been set up, and because of COVID, a single point of access was set up early on last year to make sure that if there was any sickness, that no school was disadvantaged through not having somebody available to them. So that even if they don't know the name, but they should know the name of their public health nurse, they use that single point of access and are able to get the support that they require. Our next steps is to make sure that we continue to deliver the projects that are underway and that are ongoing, and they are part of that 4-year SEND plan process that we're delivering, and also to make sure that we continue working on the good practice, not become complacent because we think things are good now, but to make sure that we continue challenging each other and continue to evaluate the approaches that we use. So on to the next page. So in terms of what people have said, it has been very positive in this respect. And I think that the short breaks activities is a really important one to show how a longer term piece of work can benefit the approaches that we take. So you'll probably recall that prior to the inspectors coming in last year, the short breaks was approved. We carried on with co-production to make sure that the right commissioned services were in place through joint commissioning. And we've got 2 comments there. We actually have many comments, incidentally, from parent carers, but I thought these were 2 really good, strong comments from families in terms of the positivity of the impact on their children. And Lisa Taylor, one of our commissioners, she actually went to observe the services that are now being provided and said that it was amazing seeing young children who in the past have perhaps been held back from accessing these kind of services, really enjoying it, but also their families seeing that their children can do much more than they realise they can do. And I think that's a lesson for us all with our commissioning arrangements going forward, that we shouldn't assume based on our own knowledge. We should do things through co-production, because we can get a lot of feedback from our children and young people telling us what they want to do, that then feeds into preparing for adulthood long term, so that we have good, strong outcomes for them as they move on into adulthood. Again, in terms of these KPIs, I would say we need to have a caution attached to them that, yes, we have some really strong feedback, but is this the right mechanism to tell us that we're doing the right job?
Any questions on this section? No.
I can see Kevin's hand up.
Yeah, it's been up for quite a while. Did you want to speak, Kevin?
No, I think we call this a legacy hand. I do apologise.
Shall I move on then to the next action?
Yes, please.
So this is our ASD waiting times. Now I do have an additional slide, which when we get to the end, Craig, it might be a case of us just swapping over for a moment, because as you'll recall, Debbie, last time you asked about a I can't say that word today, trajectory of what would have happened had we not had the investment. Now we've actually not only done that work, but we've been in a position where we have now got a much stronger position around our ASD data dashboard, and this has informed some really strong conversations since we last met with you that have improved the work and the way that we're working on this. So I would like, at the end of talking about action 3, to just show you that one slide, if I may. So again, I'll just focus on the second and third rows here. So we are now in a position where we have managed our longest waits. It's fair to say that last year, when we were challenged about this by inspectors, we couldn't actually give them a clear response. We could respond, but we couldn't give them a clear response with confidence about our longest waits and why those longest waits existed. I can now actually inform you about specific cases. I won't today, but I could take you through specific cases. So as an example, one relates to sorry, the word's just gone right out of my head, a translator, an interpreter that's required for a young person. Another relates to some complexities of other conditions. Another relates to family issues and making sure that those are not the actual cause of an identification of need. And so I can take you through, if it was required, I'd be able to now give you that information in terms of why somebody is a longest wait, how many longest waits we have, and what we are expecting in terms of those longest waits. We also now know what our mean wait is. So we know the number of weeks that somebody would wait. And as you'll see at the bottom of this row, that we know that we were in a position at January, which is our first point of knowing and understanding our data, that we had an average 27-week wait across Lancashire. We're now at, it's actually 16.7 weeks wait. We know where our shortest waits are, which is Fylde Coast, where we've piloted the neurodevelopmental pathway. And our longest waits are in Lancashire North, but we know that's to do with the way in which the pathway runs, as opposed to actually being long waits. So the pathway there is different from other areas in that the wait is longer for an actual wait for the first appointment, but it's a shorter wait overall. So the process through to the end of the assessment pathway is shorter in comparison to other areas. So we're having a look at the moment at whether or not we need to be adapting all pathways in the context of the correct pathway might be somewhere in the middle. So we've currently, to manage those longer waits in Lancashire North, LSCFT, our Lancashire and South Cumbria Foundation Trust, are currently moving resource around to make sure that they're supporting the longer waits in the waiting list part for Lancashire North. So because we've got robust data now, we're able to have those kind of conversations. And in fact, LSCFT themselves have said that since the investment into them themselves for the waiting list initiative came to an end, they've actually continued with the increase in service that they've been delivering. They've only reduced it by about a third since the investment ran out, and that is because they have been able to identify efficiency savings, and they've also appointed new staff to support with triage using savings that they've been able to identify for themselves. So the data has actually informed improved conversations with our providers. We've also got a situation where we have pathway navigators in place who are supporting families whilst they're waiting. That has improved the support we're able to provide for those who are less complex. Where there are cases of more complex situations, so where there is a clinical need of support whilst on the waiting list, we're currently looking at how do we provide that support, because the pathway navigators are not able to provide that support. So we're looking into the way that the pathway coordinator role, which is a clinical role, is supporting the wait, because they've been relying on the pathway navigators to provide that support during the wait. So again, it's about looking at how we adapt and adjust that waiting period around the staff that we have. So the next steps are to continue looking at the, sorry, it's staying on that slide just for a moment, Craig, thank you, is looking at the continuation of reducing the unwarranted longest waits. So now where we have longest waits, they are in the, sorry, my words are not good today, they're tripping over each other. I'm going to blame the fact that I've put so much effort into all of this that my brain is trying to rush ahead to tell you so much more exciting stuff. So in terms of the longest waits, they are generally warranted. We have a handful that are unwarranted, where we are understanding why have they ended up being in that position, but again, they are now much shorter than the old longest waits. So when the inspectors came in to talk to us, we had some people who it was being reported were up to 3 years. We didn't know whether or not they were warranted. Now we know that our unwarranted longest waits are no more than around about 36 weeks. So we can understand our length of unwarranted wait, and then we can manage those unwarranted waits so that we are continually reducing those down. Because of some of those unwarranted longest waits, we know some of it is to do with the number of increased referrals, and we are making a further funding request to support that work going on. The implementation is the next bit of the sustainability model. It's not enough simply to be looking at, warranted versus the unwarranted. So a warranted wait is where it's necessary. So that could be because of age. It could be because there's got to be further observations. It could be because of the complexities of a range of health needs and helping to understand what is happening for that child or young person. An unwarranted wait is because of the length of the waiting list. It could be because of somebody having been encouraged to have a referral for ASD when that might not be the appropriate support. It could also be that the support that's required needs to start within the school through reasonable adjustments. And that then leads into the next bit that I was going to say, which is about our sustainability model. So we were invited to bid for funding from NHS England for innovation in autism, and we've called that Landscape, the work that we were given funding for that. That is Lancashire and South Cumbria Autism Project and Evaluation, and that includes a range of pieces of work around innovation with autism, and that includes a digital referral platform, which will have pop-up boxes that tell people, be that a teacher, a teaching assistant, a SENCO, a healthcare practitioner, a GP, a parent, so whoever is filling in that section, a pop-up box will come up for the mention of certain things with suggestions of, did you know that you can access this peer support group? Have you tried this form of reasonable adjustment? Did you realise that you can use Autism Education Trust, for example, which is a licence that Lancashire County Council pays for the SENCOs. There's some resources that are there for the SENCOs to access. So those pop-up boxes will support that graduated response through Landscape. And then the other part is Autism in Schools project. Now, I must give a caveat of, whilst we've informally been told we've received that funding, as at Friday, we had not heard formally in writing. So there is a slight caveat that although we've been invited to all of the meetings that are about mobilising this project, we don't know for sure if we've received the funding. We presume we will hear this week. Autism in Schools is about having healthcare practitioners working with schools and parent carer forums set up within a school environment for 13 schools across Lancashire and South Cumbria. So it's a pilot, it's a small group of schools, but this helps us to understand how increasing that support for schools from health to understand better about how to support somebody whose need is identified, then you can actually reduce the longer term impacts of waiting for health to do something when health perhaps can't do anything further than giving a diagnosis. So it's about us becoming much stronger at how we're joined up between healthcare and the school environment to be able to support families. And we're all, including the parent carer forums, we're all really excited about this and keep our fingers crossed that we are receiving the funding for that. So that's our sustainability model using landscape and autism in schools. And it was really helpful that that Autism in Schools project came through, because when we were doing landscape, we were saying the one bit that's missing from this is including the schools. And the day that we submitted our bid, we were invited to bid for Autism in Schools. So that was really useful that we got that. So the next slide, Craig, you were premature for me before, but you can go on to it now. Thank you. So I mentioned before about 100% of those who've responded have told us that the Pathway Navigators are an exceptional service. Our commissioners are reporting that they're having much more meaningful conversations with providers as a result of our ASD data dashboard. One provider is making sure that, having identified the variability of the pathway, that they adjust where we require them to do so. And in fact, on Friday, that provider reported to me, they invited me to a meeting, so that was LSCFT, they invited me to a meeting with LTH, and both providers were talking about the greater flexibility they've now got. They said they've always worked together, but it's perhaps been more in silos previously. And so now they're in a position where actually they're flexible together rather than working in silos. So again, the improvement in the way we're working together is impacting in the actual services. And I thought it was really helpful again to put two pieces of verbal feedback from people. So one from families about how they've noticed a difference because of strategies that they've been given, but also from a service manager. And this is something that we think will help to free up time for those more complex cases I mentioned earlier on, that the clinicians are finding that the navigators are freeing up around about 2 hours a week for their nurses. So we hope that that will then help to support that part in the pathway that I mentioned before, where people are on the waiting list but have more complex needs. How do we support them where it's clinical support that's required? So as you see there, we have reduced waiting times, and I think that's a much more important KPI than the KPI of feedback from families, that we are actually reducing our longest waits. So Craig, would you mind if I just, I think you need to give me permission to be able to share. I can't automatically share. I just wanted to show the trajectory that was requested last time, if I may. So, whoops, wrong one. Thank you. So you'll see on this slide, and I will share this with you all after today's meeting, but we just finalised the dashboard as it stands with other providers in it as well on Thursday last week. So my apologies, you've not yet seen this. But in terms of the trajectory, the black line illustrates where we would be today. So here we are here today. If we had not put any investment in, and carrying on through to next year, if we'd not put the investment in, that you can see based on the level of referrals we've been getting, the level of increase from that level of referrals that we've been getting. The blue line is if we had used, well, we have used the investment into our providers, but without the 180 young people who've been seen by Clinical Partners, which is a partner organisation that have taken on some of the work for us. They actually are working really well on that 180, and we believe they will have seen around about 200, in fact, by the end of this month. So they've increased the number that they've been able to see. The orange, darker orange line is with that 180, and then the final line is if we receive additional funding and are in a position to be able to put that into the partner organisation who are able to provide a high level of service. So you'll see that the points where we did data cleanse are also identified. So those data cleanses helped us to better understand where we were at with our data. So the first one was actually, I think that was, yes, so that's April earlier on this year, end of March, I think it was actually this year, so end of the last financial year. And then we had an additional one in June that helped us to make sure that we were in a much stronger position with understanding our data. So we are in a position where the investment is demonstrably making a difference, but at the same time, so is the increase in the number of referrals. So it's really important that the sustainability model that we're adopting around landscape and autism in schools carries on. And we do hope we'll get additional investment, because that actually will take some of the pressures off. But it's not only about waiting list initiatives, it's also about the work that has been happening as a result of the investment that has helped our providers to understand where they can make changes that then become ongoing, long-lasting, sustainable changes. And so it's important that we see it in much more of that rounded perspective. So I hope that helps, Debbie, from that question that you asked last time, in being able to see how the investment has made a difference, but so has the number of referrals, that it doesn't change our position from start to end significantly, because there are more people being referred, and we have to address that longer term. That is actually a national issue. It's not only a Lancashire issue. And it is something about a culture of believing that you have to have a diagnosis to get support. And so families, and we hear this incidentally from healthcare practitioners, from teachers, from staff across the board. So all of us need to change the language we're using, because people can receive support. You do not need an education healthcare plan to get support. You do not need a diagnosis to get support. But I'm also hearing from colleagues across the country, they experience exactly the same problem. So somehow or other, we've got to start changing that culture and behaviour to make a change around this desperate need to get a referral and to get a diagnosis. So I'll stop there on ASD for any questions.
Good. Oh, Councillor Townley, and then followed by Debbie.
That last point, Zoe, is especially. Oh, where's everyone gone? Oh, there you are. Is especially pertinent, because that's the kind of thing I'm getting back from people. No one will do anything for me until I've got a diagnosis. So who is telling people that they have to have this? Is it the schools? And then these people are chasing their GPs, and their GPs are saying, well, their GPs are not saying whether they need one or not. Their GPs are simply saying, well, I'm not going to do it because I'm too busy. So and I know that at the end of the day, we're the ones who are getting blamed for this. So where is this determination that you've got to have a piece of paper that certifies that you have a diagnosis coming from?
Some of it's coming from families talking to each other, and that is problematic, because that's the bit we have absolutely no control over whatsoever. However, we do hear that it is said right across the system by some staff. So we are looking at, as part of our calendar of events going forward, we are looking at what we do, and I'm in the middle of talking with Amira Helm, who is the specialist teaching unit lead, around doing some videos that we could get out to schools, and that we'll also use within healthcare as well, to get that message out there about the fact that you don't need a diagnosis, you don't need a education healthcare plan to get support. So some of it we can't control. Some of it we can control, but also what you mentioned about GPs. So GPs can only respond to what is said to them, and they do that. They also are looking at the referral form as it stands, and they're going, whoa, that's far too detailed. Unfortunately, the referral form is not intended for them to do all of the referral and for it to be done overnight. So within landscape, one of the things we're looking at is how we engage the right people in understanding the process of using that referral form. So we hope that the digital platform will help to make sure that people realise the small section they need to do, but also the fact that we expect for most children and young people, the form will be completed over a 6-month period, or up to a 6-month period, because it's really important that support offers are put in place at the time a need is identified. Many people don't need anything more than reasonable adjustment. And we've heard from families recently, if my child could be allowed to come in 5 minutes past the hour, they won't be trouble. but the school are reluctant to let them do that. This is from family, this is not my interpretation, but school are reluctant to allow that because then others will want it.
Yeah, I mean, I can quite see, I mean, we are in effect going to create, on the flip side, we are going to create a kind of road for our own back, because every single parent and everybody feels that their children are very special. Every time there's a problem, they're going to say they need special attention. And I can quite see the schools can't cope with that. And I also see why the GPs get exasperated or frustrated by the need for this constant ask for diagnosis. Just going back to the GP side of it, the GPs do sit, I think, on the various health and wellbeing boards that are that do run in the counties. I mean, sorry, in the boroughs. Just as a matter of a suggestion, is it worth someone going from us to those meetings once and saying to that GP, who then obviously disseminates all the information down to his particular units within the borough?
And we also have primary care networks as well, and it's
I'm just thinking
through those as well.
I mean, in particular, the people on my side in Burnley, Dr. Fleming and Dr. Davis would, that would be so helpful, just to say to them, this is what you can say to people when they come to you with this, that it's not overnight and they don't really need it. But I can see this is going to cause us a huge problem until people learn that that sometimes children are just naughty, and it's not nothing to do with having to have some form of extra help. I mean, but that does mean that we're going to suddenly dip, I think, on all our action and
I think we've got the mechanisms to improve things, and I think that is positive, but it is a national problem. But I noticed Hillary's hand has gone up, and she's
sorry, I'll shut up now, but that was my concern.
Yeah, I think there's Hillary and Sarah wanted to come in on this point.
Yeah, so I think it's a very valid point, isn't it? And I think in terms of where the idea has come from, that everybody needs a diagnosis, I think it's one of those things that's sort of, it's almost become myth and legend in its own right, perhaps because we haven't been providing as much support or as much information as we could have done. And I think as this programme goes through, and as we get into things like autism in schools and landscape, and we develop some of that support, I think it will be really helpful for us to keep you all updated, really, so that we can get some of those messages out across the whole of the population, because I think it's become quite ingrained over the last 5 or 10 years that actually, unless I'm on a waiting list for a diagnosis, and I get a diagnosis, then I'm not going to get the support that I need. So I think it's quite a cultural thing, actually. I think that we need to reverse, and unfortunately cultural things do take some time, don't they? So I think we do have a bit of a process to go through, but at least we've started that process. And I think your suggestion, Councillor Townley, for talking to the health and wellbeing partnerships locally is very, very helpful one. So thank you for that.
Sarah, did you want to come in on this point?
Yeah, just briefly, I think what you've raised, Cosima, is that broader cultural shift, isn't it, which is not easy to do, but we know through this work that our more accurate use of data is helping us to shift, I guess, our support offer down from the critical to the more preventative. So some of the things like the cabinet reports that went on the SEND sufficiency last week, that is because we know we've got 10% more children in Lancashire in special schools rather than in mainstream. And it is that kind of culture where some of our schools are perhaps less tolerant or less able to support those children. So one of the things that we've done is Sally's service, the inclusion service, have developed a SEND toolkit so that rather than be dependent on the outcome of an education, health and care plan, the schools are supported to identify and meet need earlier. So I guess what I'm trying to illustrate is there's a lot of other key interdependencies to this work that more accurate use of data is supporting, that will over time shift the balance from the critical to the preventative. But it is, you know, it is, as Hilary said, a big piece of work, but I think we've got evidence to show traction on some of that.
Cosy, did you want to just come back very quickly?
Does this mean, Sarah, that schools will need another person to pick up on this toolkit to take it through, so it alleviates the clogging up of this in the classroom? Are they going to have to allocate?
No, I don't think we're creating a demand for more capacity. I think it's about how we use our current capacity. So, you know, schools will have SENCOs, you know, SEN coordinators, and what the tool, and they get the notional funding. So, you know, they get the £6,000 in the budget for children with additional needs. And it's this tool is enabling them to show, before they make a referral for an education healthcare plan, what have they put in place, applying their notional funding to prevent, you know, to meet needs, so it's not dependent on it going through that education care or health and care plan referral, because we know there's been a surge post-COVID nationally, and it's not about the plan, is it? It's about identifying and meeting need. So that's what it's aiming to do. So it's not about creating more work, it's just working differently.
Debbie?
Thank you. So I've got a question, but to also sort of reflect on the conversation that we're having at the minute, from sort of a personal perspective of a parent of a child who has ASD and who's been formally diagnosed, and also chatting to a lot of other parents who are sort of at different stages in the pathway. I think we need to remember almost that we treat young people who possibly have developmental conditions the same way as we would as a kid who might have a broken leg. You know, we wouldn't say to a kid who's probably got a broken leg, oh, just wait a little bit, you know, your mum and dad can get you crutches and can sort of be doing things in the meantime. It's really important for parents that they have access to diagnosis from a sort of an emotional and a practical perspective. You know, they have a right to know if the children do have a developmental condition that will affect them every hour of every day, both from a school and a personal perspective. So I'm really pleased to see the increase and the speed and the pace and the additional young people are able to get to that faster through the work. I think sort of my view that, again, from practical experience, is a lot of this sits with schools. So GPs can refer through to CAMS to help get a diagnosis, and we need to speed that up. But the reality is that in schools, there's a hierarchy of support. So young people and parents are told, well, we can make some reasonable adjustments, but we can't do absolutely everything unless you have a diagnosis, because otherwise we just don't know. And of course, we'll do some things, but we need a diagnosis to go sort of over and above that, because you then have legal protection under the Disability Inequalities Act as well, and they tend to respond to that. And then again, you get reasonable adjustments, but you're then told, well, we can only do so much unless you've got an EHCP. So I think we just need to sort of listen to patients' voice around it and practical experience, and all that work about helping GPs know that you can get to stuff, or parents know that you can get to stuff without a diagnosis, is really, really important. But we do need to really keep our eye on the ball for this, because it does make such a difference, and it is an access point. The question I was going to ask is around sort of the provision. So I was really interested, Zoe, when you were talking about the variation in the pathways. So about some providers, it's quicker and easier to get to diagnosis. Others, it takes longer, but they get to the support quicker almost, and it sort of speeds up. So I'm wondering sort of how we'll be able to tackle that variation in the pathways. Is it through contracting, or is it through supporting those really practical, positive dialogues that you've just mentioned that are happening, for example, between LCSFT and LTH, where they can actually do things now if they work closer together better to get some of the issues out of the system out the way?
I'd say it's the latter, but with a bit of the former. So it's having commissioners as part of the conversation as well to help, because of course, the word commissioners always makes it sound as though what we do is we buy, but actually what we do is support. It's a lot of that understanding where redesign is needed, where improvement is needed, and many of us are program managers with experience of helping services to improve. So it's about bringing that whole raft of experiences together and having open conversations that help us to deep dive, get greater understanding, and get to a place where we then have the right pathway across a variety of services. And as I said before, I think probably the appropriate one is somewhere in the middle between two sets of pathways that exist. Both have their benefits and both have their less beneficial elements to them. So I think it is about looking for where do we find the way in which we can provide the best level of support leading up to the assessments, through the assessment pathway, and for those who then receive a diagnosis, post-diagnosis. But it's not about simply telling one pathway you've got to change to be like that pathway, because actually that might be that we're moving things to being the wrong approach. The other thing I think is worth mentioning with what you were saying earlier on as well is we shouldn't lose focus of the fact that we still have refused referrals. So referrals that are coming in that are, in the past, the term that was used was inappropriate. It's not that they're inappropriate for referral, it's that they're not necessarily on the appropriate pathway, or they're not necessarily getting the appropriate support. That has been reduced, and we've understood more about where refusals do happen, but we still hear from families that they have been refused a diagnosis. And again, this is something that's important, that not everybody requires a diagnosis because a diagnosis isn't the appropriate thing for them. So, we need to make sure that those people receiving a diagnosis, who do, as you said, do have a right to that diagnosis, are the right people. And we need to ensure that waiting times, waiting lists and the assessment pathway are not clogged up with people who we know right from the start they would not be getting a diagnosis. We still hear of those from hearing it from healthcare practitioners and teachers who are told that they should go on to the pathway just in case. And actually, just in case isn't the right reason to be going on to the pathway, and that does affect it for those who genuinely need to be on the pathway. And that's part of landscape as well, to make sure that we understand much clearer about the pre-referral part and making sure that we have got that graduated response starting within the pre-referral, going through the whole pathway.
Thanks for that, Zoe. Shall we move on to action?
On to the next action. So this is transitions in healthcare. This is the one, as you'll recall, that has one sub-action that's not completed. However, I believe that the work that's been done right across this piece of work actually prepares us really well. So I'm not overly concerned that we've not ticked the box on that final sub-action, because we are doing everything and have done everything required to get this in place. We also shouldn't lose focus that with transitions in healthcare, I passed my 20th year since I came into the NHS the week before last. And when I first came into the NHS, we were talking transitions in healthcare then. So this has been a long-term issue, and I believe it was probably going on before I came into the NHS. So it's really important that we recognise the amount of work we've been able to achieve in just 1 year with something that had been quite difficult for a lot of people to grasp and understand what they needed to do. So we have delivered in the main on what we were asked to do by the inspectors. The two things that I feel I cannot prove, and I will use the top box on this one, on this occasion, the bottom bullet there says poor experience for young people. I can't prove at this stage whether or not young people are having a good experience. Part of that is because when we have used the surveys, and this is the one time the surveys have actually been really beneficial to us, we've got a diabolical response rate on the surveys, and that response not in terms of the number of respondees, but in terms of what they've told us. And they've told us they've not had a good experience. And that's not moved in the 12 months. So we did a deep dive with young people about why has that not moved. And this was a little bit of a dull moment for me, because what they said back to us was, if you have had a smooth transition, you don't notice it. So therefore, the only people who are going to give us response, or in the majority, the only people giving us a response, are those who've had a negative experience, because you've not noticed exactly what a transition should be, a seamless transition from children's services into adult services. So a survey is actually not a good way of testing whether or not it's been a good experience. So we know that instead, that what we can say is that now we have a consistent approach right across the integrated care system, not only for Lancashire, but right across Lancashire and South Cumbria. We have absolute clarity of our strategy for what we're doing with that work, for our consistent approach with what we're doing, and for the pathways that we're using. We also have agreement across the ICS that the Ready, Steady, Go, Hello approach, which was co-produced nationally a few years ago, that is the approach that every provider would use, but also that they would adapt it according to need. So that's back to where we would need warranted variation. So if it is warranted that we move off the Ready, Steady, Go, Hello, that we would do that. But actually what providers have said is it's not a whole-scale change to Ready, Steady, Go, Hello. It is actually an adaptation to it. They're also using 10 steps to transition, which was created by Alder Hay, working with young people to help understand that transition process. We have now managed to create a situation where we have got adult services engaging with us where it's appropriate to do so. At the beginning of the process, we were trying to engage all adult services. What became clear quite early on was that we only need to focus on adult services case by case, because different young people need engagement with different adult services. So we changed the approach we were taking with that, and now individual providers have developed either a SEND improvement group where transitions is part of it, or a transition group in 2 cases where they are then enabling appropriate adult services to be part of the conversation. We've also got good data for transition now. We are reporting on the first 2 parts of that, which is helping us to understand the cohort. And the 8th of November, I think it is, I might have the date slightly wrong, but it's around about the 8th of November, we've got our first reporting of all our data set for transition. It's taken longer than we would have liked, and that's because our business intelligence teams weren't able to do the initial work. The work on this is about template changes, about coding changes, and that coincided with them needing to respond on data for COVID. So it was difficult for us to have the capacity from provider BI teams to be able to support the changes. However, they have been engaging with us since they gained that capacity. And in doing that work, they have initiated the first parts of the data rollout and initiating the second parts at the moment. So we know that we'll have October as the first reported month on our transitions data. That then helps those transition groups and the SEND improvement groups to make sure that they're addressing the right cohorts of children and young people in the right ways. They'll be able to identify service by service who's got a SEND plan, who's had a SEND conversation. We have identified that we need to add an extra bit into there. It may not be through data, but we need to also be making sure that conversations are being had with families, because the young people are telling us that they appreciate a better experience than their parents. They've also said to us, please stop asking our parents about a transition arrangement when actually this affects us. And so you need to only prepare our families that they need to let go. And we've had that from the mouths of the young people. And I recognise that, you know, September 11 years ago, I still drive on the M6 seeing people with their cars full and get emotional that 11 years ago, I was letting go of my little girl. So, you know, it is something that all parents go through. And perhaps we're not good enough at helping families to do that letting go process. And we perhaps need to support them from when the young person is 14 years old rather than leaving it till later age group. But we do know that we're improving on the way that we're doing the work. We have got a sharing and dissemination of learning embedded into our processes now. And the task and finish group that was set to complete on the meeting that we've got next week was due to be its last meeting. The providers have actually asked for that meeting to continue. And I think that shows a real strength in how they are now connected. And we have adult services starting to engage with that group as well. and finding it really helpful to be engaged with that group. So the fact that our providers want to continue because they are finding that the sharing and dissemination of learning is invaluable to them. But there's one final thing I'd like to say on this slide that is really crucial, that illustrates the importance of what we have done over the last 12 months. And that's that I have had approaches from integrated care system program managers who are engaged with, not engaged, that's the wrong word. And now I've said engaged, can't think of the right word, but they're told as part of their work that they need to deliver on transition. They have been in touch and said, we need to learn from what you're doing in SEND, because we're hearing across the system of the great work you're doing on transitions in healthcare for SEND. So I've met so far with the woman who's leading on the programme of work for continuing healthcare, and she wants to embed our processes from continuing care for children and young people into continuing healthcare for all age. It's described as all age, but that at the moment is adults. So that we reach a place where we've got an all age approach, and that transition becomes the norm within continuing care and continuing healthcare. Within that, she's talking to me around how we can link in the equipment side of things, which links back to the joint commissioning and Action 2. So we've got a great join up there going on. And then the woman who's leading on the programme for medical complexities, I've had my first meeting with her, and again, she wants to adopt the approaches that we're using for SEND transitions in healthcare. So I think it's really important that we recognise that other parts of the system are seeing that this is actually making a difference, that it's got traction, and that it's an approach that we should be using for other programmes of work as well. So it helps us to see that, yes, we haven't ticked that final box on a sub-action, but actually that's not the most key thing. That idea of sufficient progress being made, we could not be in a position where we've got others wanting to follow our lead if we hadn't made sufficient progress. So it's really crucial we recognise that. So our next pieces of work is continuing the rollout, which is our phase 2, which we would have done much sooner had we not had COVID. But that rollout of the further inclusion of adult services, the further inclusion of primary care, is part of the work we're currently undertaking. And incidentally, we've had primary care networks start to approach us, asking us to start working with them now on this transition work. And I think, again, that's powerful that they said to us, leave us to it until September. We didn't have to go to remind them. They've come to remind us that they want to be involved in this work. And then the final part is to review and improve pathways on an ongoing basis, based on that feedback that we're getting from young people who are really engaged with this work. Parent carers are saying that they would like to be involved with it too, and we're looking at setting up, for going forward, for a sustainability model, an expert by experience panel specifically for our parent carers going through transition, so that they can be engaged in the process of improvement of involvement of parent carers as well. So on to the next slide. So again, we've got some comments that have been helpful. I have entered on here the risk. It is a minor risk, I believe, but we were asked by DFE to include a risk log. This is the only risk in terms of delivery of the Accelerated Progress Plan. And you'll see there the low statistic of 33%, but I've explained to you how I believe that's been really helpful to us to understand that actually, in a way, that number should be getting worse, not better, because the only people should be telling us that it's bad are those who've had a bad experience, and everybody else. So we should have a smaller number. It's the number responding on this that becomes important in terms of the worsening picture. But actually, the fact that it's a lower number giving us a dreadful picture will tell us the services that we then need to target and make sure that we're providing that targeted support to them, because actually everybody else then is receiving that seamless support for transition from children's to adult services. Any questions?
No, there don't seem to be any. Any, Zoe? Oh, sorry, Debbie.
I've got Kevin and Debbie.
Oh, I can't see Kevin.
Hi Zoe, thanks for walking us through that. Just had a slight niggle in my head about whether or not we are, or you are, trying to put too much of a gloss on that last target you just discussed. I can understand your logic, but it would be it might be sort of assuming too much to say that only the ones who haven't are going to respond. So I know how we're going to be really clear about that and not sort of jump to that conclusion.
We do need to be continuing to use surveys. One of the things we identified is that having a generic survey didn't work. So we're actually working with our providers, and they've started to do the surveys within provider at the point where somebody receives the start of that transition process and then through the transition process. So it becomes provider-led and service-led as opposed to system-led. So I think that's the first bit that's really important in this. So we've learned from the lack of value, if you like, of this particular survey, and our providers have been really eager to find out at their locality what is that experience like. That then helps us to make adjustments service by service where it's required, as opposed to having this very generic picture of overall somebody saying, no, I had a bad experience, but us not knowing where to target that support. So that's the first bit. The second bit, and linked to that first bit as well, is that some of our providers have then gone and surveyed practitioners who've said that they feel they lack confidence in having a conversation around transition. So that means we know we've got a workforce development need that we need to address as well, and that's been helpful to learn. The second point is that actually we're thinking that it's, only time will tell on this, we're thinking that it's our data dashboard that will inform us more around the work we've got to do. So how many children and young people are in the cohort, how many have had a transition conversation, how many have been encouraged to use a transition plan, and those then using the transition plan, how many are using it. And then the final bit is looking at, we've got the LD&A, the Learning Disabilities and Autism Healthcare Passports, and we're looking at, do we extend those for people going through a transition process? And again, then it's a piece of data around and how many would be using that passport approach. And I have to say, by the way, that looking after my mother is on the other end of the spectrum, I've decided I'm going to start using a passport for my mother to help her because she forgets things. So I can see the value of those passports from personal experience. I noticed Hillary's put her hand up. So before we go to Debbie, it probably is to add in a bit more to that as well, Kevin.
Thank you, Zoe.
So Kevin, I think the other thing that I would say is that obviously the best way to start a transition process is to start it when somebody is younger, so around the age of 14. So if we think about the people that we've been surveying recently who will have transitioned, actually they won't have had the advantage of that full process that we've now put in place. So actually what we would also expect to see over the next 2 years is a much better experience for anybody who's starting that process now or started it within the last year to come through. So there's a lag time, for want of a better expression, I suspect, because some people who've gone through this year and we've surveyed they'll have had a much foreshortened process, won't they? And it probably won't have been as good as we would want it to be for those people who are now starting the process and coming through. So I think that's probably just another thing we need to understand and recognise within the figures that we're showing. So I think you're right to not allow us to get complacent, because we don't want to get complacent, but I think there's a number of things that we would want to just follow up on and make sure are happening over the next few years.
Okay, thanks, Julie. Just a final point, which is sort of generic really to all of these actions and results. Where you're asking for sort of feedback on how services were experienced and was it good, bad, indifferent, I think it's really critical that the work's gone on behind that to actually try to set realistic levels of expectation.
Yeah.
Because so many people have different views, and it came to me while you were talking about the number of people who may be misinformed about needing a diagnosis. Well, if that's their expectation and they're not getting a diagnosis, they're never going to tick I'm a really happy person box, are they?
Yeah.
So I just wondered whether going forward there needs to be consideration of perhaps some more resource in terms of internal, but particularly external comms around, is there a simple way of getting out messages that say this is what you should be expecting? And if those expectations are flawed, how do we sort of correct those? Just a thought. Thank you.
I think that's right, Kevin. And I think it goes back, doesn't it, to what we were talking about a few minutes ago about the whole cultural, the cultural thing about expectation and myths and legends being developed because there's a vacuum. And I think one of the things that I think because we're much stronger now in our understanding of what is happening and what young people need, want, and what families need and want, I think we can be clearer about some of those communications. So in our next iteration of our plan, I think communications and how we develop that is really important to get some of those messages out now. I think we were perhaps not previously, we'd have been not so, without all the data that Zoe and Sarah have been talking about and working on, we would have been in a much more difficult position to try and develop some of those messages and try and get some of that out to the public. So I think we're in a much better position to be able to do that and to develop that now in a joint way.
Okay, thank you.
Thank you, Debbie. Do you want to
Thanks for that. Yeah, no, it picks up on some of Kevin's point really and challenge, because you do get concerned, don't you? And I'm sure from experience of sort of inspections on an education footing, DfE, they'll hone in on areas of risk, won't they, or areas that they perceive to be underperformance, and they'll really grill and look at sort of data and evidence around it. So I sort of welcomed that evidence base that you've talked us through to show we understand it's still poor because of X, Y or Z. We've already done X, Y and Z to make it better. It's just it's too early to be able to perhaps see that, but there is a robust system in place to be able to gather that and make sure that we're fleet of foot if we don't start to see those figures increasing. And for me, I'm sort of wondering, could this be a limiting grade? So in education, when Ofsted come out, there's certain areas that are a limiting grade, where if you don't meet expectations of sufficient progress, it sort of impacts in other areas as well. Is there a risk that it might work like that? Or if 4 of the 5 areas are sufficiently robust, will the judgment be tempered by that? Or is there a risk against this one in particular that it sort of affects how they see everything?
What I'm informed, and I don't know how accurate this is, Debbie, so please forgive me if this isn't what ends up happening, is that we could find ourselves in a position where we pass all 4 of the other actions, that transitions, we might then be asked to spend another period of time. But I have to say that there's little that we could have done differently. We've learned, the reason I'm saying little, we've learned things as we've gone along. So, now with that benefit of hindsight, I might have started differently, and there's some other bits that we could have done differently because of the learning we've gathered over the last 12 months. Transitions in healthcare, by the way, wasn't a new project to me. In a provider previously, I've worked on transitions. So even with the knowledge I brought to it, I still feel I've learned a lot, and we could have perhaps done a handful of minor things differently. So little we would have done differently, and little we could have done differently due to the COVID situation. Adult services were in a position where they just could not get engaged in January. If you recall, we went into lockdown, and was it the 4th or 5th of January? So that took capacity away. It took capacity away in terms of BI as well. It took capacity away in terms of other contexts. Primary care then getting involved with the vaccination programme. So, there is a caveat to this. And we do know that there are other areas that have been given a slight amount of leeway due to COVID, that if it has been a COVID related issue, that they have been unable to pass through their monitoring. I'd be very disappointed on this one if we're not allowed to pass on it, because we have put all the foundation in. And Kevin, I absolutely get what you're saying in terms of how we can sound as though we're glossing over things. All I can tell you is that I know we have everything in place now to enable this to continue. And that is the most crucial bit. We could have done pieces of work that we're about being able to demonstrate to the monitors in September that, yep, we've done everything you asked, but come October, it would fall apart. I'm proud that we've put in place a sustainable approach that enables this to have long-term, further-reaching impacts that is not only going to benefit children and young people with SEND, but actually will benefit children and young people right across the board.
Thank you very much indeed. Thanks, Zoe.
Could I also come back on Councillor Townley? Earlier on, you asked me about following through. The answer to that is that no, we haven't followed anyone through. The data will allow us to follow through the whole cohort. However, I really like that suggestion. So I'm thinking that that might be one of the things we put in place for our ongoing piece of work around transition, as we then link back into the preparing for adulthood as an overall piece of work. So I really want to thank you for that suggestion, because I do think that's something that will help us to get a much clearer picture of where blocks come up or where there are issues that we need to address. But the cohort we're following through from the age of 14, and then I think that's something that would strengthen that cohort's experiences to follow through a small group of young people.
Gozzy, did you want to?
Just to follow that up, Zoe, I just wondered whether if it was a kind of sorry, this might complicate it, but it wasn't necessarily it was something that you could take on a kind of monthly or every other monthly basis, and it's someone that's not just tracked through the system. It's just someone who's picked out to see, you know, whether what was meant to happen has actually happened. And it doesn't necessarily have to they don't have to be rung up necessarily. It's just whether their case notes have actually been kept up to date.
Yeah, great idea. So we do it based on the clinic appointments that they have. Yes, thank you.
Sarah?
Yeah, I was just going to pick up on Debbie's direct question about the limited judgment and the framework. It's just worth saying, isn't it, Zoe, that the actual inspection framework is changing. So when we hopefully come out of the 29th monitoring visit and they do hopefully agree that we've made sufficient progress in all 5 areas, there is a new inspection framework which is expected to be launched September 2022. And within the new framework, there will be judgment. So at the moment we get the letter and it's a narrative, whereas it will be more like the school judgment where you actually get, you know, an outstanding good RI or inadequate judgment. So there will be a change, but there isn't a limited judgment as in a school one at the moment, Debbie. It doesn't work like that, the current framework. But the other point I was just going to make was, and I've just put it in the chat, it's just because I think it's really good what you're describing, Cosima, about the potential to track. And I guess what we have done, what Sarah Gorst with Lorraine Stephen, who is our lead for preparation for adulthood, the broader piece of work, they are looking at case studies, so picking up from an education perspective, a health perspective, and a social care perspective. What would it look like if we were getting this right, and then looking at those cases and seeing how far or close they are from that, and that is helping shape how we improve things moving on. So we are doing that on the broader PFA work.
Just going back, so do you have to alert them? It's just that I'm thinking that this kind of work is done. It's a wrong term, I know, but I'm going to use it as kind of underneath the radar. So you're not worrying anyone that they feel they might not be getting what they've been promised, but you can see whether they have hit those targets or whatever. So it's just a kind of dipping in and out. And you can put right if, and I'm assuming because your staff are so perfect that it will always hit those targets. But it just means that no one's getting worried. But you can say, I'm going to look at Alice's case now. I'm just pulling that out of the air this month. Oh yes, I see that she's got to that point, but there seems to have been a slight log jam here. So let's just have a quick discussion and see if we can tweak that.
Yeah, so that it works exactly.
But without worrying them, if you get my meaning.
No, it works in exactly that way in terms of the audits that I mentioned before, you know, around the education, health and care plans, that you could have a dip sample of plans, you know, and have a theme that you're looking at, like child's voice, you know, and see how evident child's voice is within that plan. So that's exactly how it happens in the audits. I think what you and Kevin are describing is slightly more than that, isn't it, about progressing a young person throughout the system. And I think that's what Zoe's saying we could look to do. But I think in terms of the broader preparation for adulthood work, we are looking at current cases, and I guess it's more of a retrospective. What can we learn from this, where there's areas for development? But I think your suggestion is a bit more, let's track them right through the system, which I think is, everybody agrees, would actually be a really useful thing to do in a way that doesn't upset them, as you're describing.
Thank you. I can't see anybody else with hands up, so would you like to go on to action 5, please, Zoe? We're pretty much on time, but we need to keep an eye on time, I think, now.
It speeds up from here. So local offer is action 5. There wasn't a huge amount said within the letter, but I think that in 2020, but I think there's a huge amount within the those few words that are there. So we have been told that we needed to increase awareness and that we needed to complete the, as it was then, new offer, which was the local offer web page. Incidentally, we have got a new page, landing page, that will be ready hopefully at the end of the month. But at the same time, a lot of other work has been going on. So you'll remember that we have our new local offer development officer who started, well, she's not so new now, who started in January. We've also now got a Facebook page that is used quite significantly by parent carers, the feedback being that they're already on Facebook, so it's easier for them to use that. So we're going for more of a blended approach, if you like, around the opportunities that are available for sharing information. The local offer web page simply being seen as one of those routes. We still have some issues related to the local offer web page because of it being on the local authority website. So it makes it difficult to do certain things, and also it's then restricted by the approaches that are standard within the local authority. So, for example, at the moment, we're having to look into how we can market the local offer better through things like email signatures, because it's viewed by the local authority as being marketing. It makes it that local authority staff are not able to do that. And yet we do have a requirement to raise awareness. So it's finding that balance around those things that prevent us doing certain things and those things that we are required to do. But it's been a really good time using the local offer development officer of finding out how people want to receive information. The Find newsletter is something that we looked at as to whether we would carry that on, and families all said, who were surveyed, all said, please keep it going. It's an invaluable source. So as you can see here, we're looking at local offer now beyond being simply about a local offer website page. But in terms of the website, a directory has now been put onto there. It's got 850 services that are recorded there. That is growing. So in January, that was at 200, I think, and it has grown since January to 850. It has been initially soft launched with parent carers who gave positive feedback and has now been hard launched. It would have been launched fully earlier, but this is one of those scenarios where we hit against a significant issue that the local authority website made it difficult for the directory to go live. And it was an IT problem that nobody predicted and took quite a lot of work. And thanks to the local authority IT colleagues who made that work eventually, because I believe it took quite a lot of effort from them to make it work. But that directory service later than we'd anticipated, but is available to families. And the feedback is that it's information that they want access to and that they're finding it really useful. Alongside that, we have funding that is being used to improve the health input to local offers, and a video linking back to our transitions in healthcare and our learning from that. We tested this idea with families that what we will do is upload a video. It'll be November, unfortunately. There's been a delay due to some long-term sickness of the person who was dealing with that work for us, which has now been picked up by somebody else. But it's a slippage of 2 months, unfortunately. But the video is about transitions for our healthcare providers. That might sound like the wrong way round, but families said to us that they would feel empowered knowing what healthcare practitioners are expected to do in a transitions conversation. So it's going to be a short video that will say, as a healthcare practitioner, you're expected to do this, that, and the other. Then families, when they go in for their appointments, can say, I've watched this video and it says you're going to have this conversation with me. You haven't had it with me yet, and you're telling me that's the end of my appointment. When do I have the conversation? So we're hoping that that will empower families as much as train up our healthcare practitioners. Our ongoing work is to carry on with improvements to the local offer, responding to the feedback that we're getting from parent carers. We get high levels of responses on this feedback, incidentally, so it is something that families want to tell us about. We will implement the changes that has been co-produced and is currently being co-produced in relation to the health input, and we will ensure that the local offer is kept current and up to date and is meaningful to users. And that includes the blended approach, the continuation of the blended approach that families seem to be finding really useful. And so on the next page, we have had 80% of people telling us that they could find the local offer. We got some feedback from the Department for Education about 6 weeks ago that people couldn't find the local offer. So we decided we'd go off and find out, can you? Now, this has been a really useful bit of feedback from families because, of course, we've got 19% saying they couldn't find it or find it with ease. So why couldn't they? So we've been finding out about the keywords they use to look at adjustments to keywords in the local offer to make sure, and this is all getting into technical stuff that probably all of us here in this room don't necessarily understand, but it's about making sure that when somebody puts in, for example, my child has SEND, what do I do, that it still would find Lancashire SEND local offer. So we're trying to make sure that we address that 19% because it's important that if you don't know that you should be using the terminology local offer, that you can still find the local offer. So we're not resting on our laurels around that 81%. We've actually found that really helpful to start to understand that there are people who know nothing about SEND who need to know how to find the local offer. We also know that the local offer is ranked at the position of 25 out of 125 for accessibility. So that's good that we have got something that people find is accessible. And they do like this, parent carers do like this blended approach. And then also we've got the young people telling us that they can definitely see an improvement with the local offer and that they've really enjoyed being involved in the discussions and they look forward to furthering that improvement to the local offer. So the feedback here, it's 69%, very close to the 70% of feedback around the local offer. And the 54%, that's an improving picture, and that's what you don't see in this particular scorecard, that it did start at a much lower percentage. I think off memory it was around the 45% mark, and so that's been an improving picture around about it being good or better than good. But also I think what's important to note there is the number of families who are engaging on the Facebook page is at 4,865, and the page was only set up it was set up a while ago, but it was only being used from January. And it's also got a star rating of 4.2 out of 5. So whilst we're not going to say everything now goes on to the Facebook, that does illustrate the value of using a number of different routes to share information about our local offer. Alongside that, we're looking at, and we launch it later on this month, a calendar of events of support. So again, that will help us to increase the ways in which people know about the local offer. And that will be support offers to practitioners as well as to families, because it's important we realise that local offer isn't only about what do families know, it's about what do our practitioners know so that they can guide people the right way. And that goes back to, you know, if we have families being told that you need an education healthcare plan or you need a diagnosis, that tells us that we're not giving people the right information about our local offer. So we need to make sure that our calendar of events expands that sharing of information for the local offer. Kevin, I do believe earlier on I stopped you from speaking when you wanted to say something about the local offer. And so can I invite you to challenge me on that one now?
It's unnecessary, Nelsa, because subsequent sort of questions and answers have really adequately covered the points I was going to make. So, but thanks for remembering.
I have to press little fingers to remind myself. What was that little finger for? Oh, that was Kevin.
Debbie, do you have a question?
Yeah, thanks, Chair. I think you've given us a lot of assurance around the work that's in place. I've got to be honest, because when I've accessed the site, I've been really open about how much better it is, been really complimentary to the team, because I know how much work's gone into it, and I know how important it is for parents and carers to be able to help themselves as well, and to be able to get to things. It's just critical, isn't it, when we're talking about communications and expectations. So my heart sank for the team really when I saw that measure at the bottom, and I thought, oh no, only 48% are saying that they can find the information that they need.
Well, that's one that's improved. So that's one that has changed. So the latest survey was only finished last week. Hence, it means that because if you recall, we do month behind all the time. So the data at the point when I sent the information out to you was the July data. So I'm really pleased that with the latest survey, it has increased from that. So it is positive. But yes, I'm with you that my heart sank for them, that it's, oh, you know, I haven't hit the 70% and yet you've done all of that work.
Yeah, and I guess it's sort of I'll leave it with you. You don't have to respond, but from a sort of a patient and public carer's perspective, it's the value of that conversation and unpicking it. Because I was looking at it and thinking, well, they're saying that they're not able to find the information that they need. So is it that they're not getting to the site at all, and you're picking up that point, or is it that they get to the site and then they can't navigate around the site, so they're getting to it but they can't find on the site the right bit for them? Or is it that they're doing all of that and they're doing a cracking job, but actually there's nothing there for them in their eyes that fits their needs? So they're getting to the offer, but they're thinking, well, actually, there's a gap in it. So it's so important, isn't it, through those different ways and different measures to have that conversation with people to get the feedback. And I just encourage us to think of ways where if we've got people who've clicked into it and clicked back out, some kind of way through focus groups or sort of parent carers forums to sit down and go through it with them and get that real richness so that we can evidence that we're acting on it.
And that's all, everything you're talking about there is all part of that future work. So we're on the same page.
Thanks, Abby.
So the last slide, I think, is just a reminder to everybody of some of those reactions that we have. I don't intend to take you through those. Actually, I said the last slide, there is another slide, but that we've included for the inspectors, which is actually the SEND plan, the priorities and the ways of working. So the reactions, I don't intend to take you through that, but that shows you that we have had some moves in the right direction around the reactions from people. So Craig, on to the very final one. So for the inspectors, we will be saying to them about the fact that we do know that it doesn't all end here, that we have ambitions for 2021 to 25, and that through co-production and consultation, we now have our priorities and our ways of working. And I think it's really important that we get across to them the message of the fact that this has all been done in partnership, by the partnership, with the partnership, with parent carers, children and young people involved, and has heard many voices. You know, we are at, I think it's 170 something voices involved in the conversations that led to the development of the plan, and about 88, I think it was, in the consultation process. And so this is really important that the monitors realise how we know we've got more work to do. It's not ended here. And that work is to make sure that we continue to ensure that we improve the lives of the children and young people with SEND and their families too. So I think we're in a very positive position where we've reached. We have made significant progress. We now have to hope that the monitors believe that that significant progress is sufficient progress.
Thank you very much, Zoe, and to everybody for the massive amount of work that's gone into this document. And I think we're in an excellent place to meet for that meeting at the end of September. So a huge thank you. If we just go back to the recommendations of the paper, we've been asked to note the progress of the APP and the 5 areas of concern and challenging question, the progress of the work, which I think we'd all agree that we've done in a lot of depth. So thank you very much. So if we just move on to item 5, any urgent business?
Before we go on to the urgent business, could I just give a little bit of feedback to all of you? And that's to say that we found your check and challenge incredibly valuable. Changes have been made as a result of these conversations. So I would like you to know that these meetings are not wasted meetings on us. We actually take your comments away. We do something different as a result. And I can see changes because of what we've done, because of your challenge. So thank you so much for that.
Just one thing I was going to ask. One of the things from the minutes last time was about informing county councillors on comms. I'm assuming that we've got comms in place, have we, for the end of September, or after we've had that? It'll actually probably be more likely to be later in October. We won't hear on the day what the outcome is. So we will be written to in March. I believe that was about 2 weeks after our March review meeting. So I would anticipate Edwina Grant will receive the letter around about mid-October. That will then start that communication ball rolling. And yes, we're mirroring the approach from last year with the send revisit. Yeah, good, because we do want to have a good. So our comms team are waiting for it and ready to move as are others. So that's good. There is no urgent business as far as I'm aware. No. Item 6 is date of next meeting to be discussed. Hilary, did you want to come in on that?
Yeah, so I was just wondering whether we do want to plan one further meeting in for after the after we know the outcome, just to agree whether it's closed down or whether it's continue or whatever we need to do. So I would have thought if we plan to have another one in, we think we'll get the letter mid to late October. So if we were to plan another one in for sort of November, I think that might be a good time. Would that be sensible?
I think that's an excellent idea, and I do think we need to have a look at what's been said and how it's fitted in and what other work we might need to take forward or not, as the case may be. But I think in agreement with everybody else, I think we should go for that early November slot.
That would be fantastic. I think for continuity it's really important, isn't it? And it would be great. I know that there'll be sort of protected communications around it, but if we could have an update just to hear how it's gone so that we all know how the team have fared, that would be brilliant in between.
Yeah, we'll make sure that happens. And a huge thanks to Sarah actually for all her work that's gone in, because I think this will be your last meeting with us, won't it, Sarah, before?
Yeah, it will. Thank you, Jane. Yes, I'll be in Islington helping them with their send preparation because they've not even had their first inspection yet. So, but it's, as Zoe said, it's been lovely working with you, and I'm sure it'll go really well. And I'll be looking out for it with a very interested eye.
Right, with that then we'll draw the meeting to close. Thank you everybody for all your time. It's been a really very positive meeting, and I'm really looking forward to the 29th because I know it's going to be very positive.
Thank you very much.
Right, thank you.
Bye.
Thank you, Jane. Take care. Bye.
Bye. Bye.
Bye, everybody.